Today's speaker is Kathy Kinlaw, Associate Director of the Center for Ethics. I know a lot of you know her, but let me just run through what she actually does day to day. She directs the Ethics Center program in Health, Science, and Ethics, and she works to integrate ethics into the medical training at the Emory Medical School. She's the lead ethicist at Emory Healthcare. She serves as chair of the Emory University Hospital Ethics Committee. She's an assistant professor of pediatrics and director of the Healthcare Ethics Consortium, which is a network of healthcare systems in the Southeast. She has served as a board member of the Georgia Composite Medical Board and a member of the Committee on Ethics and Professionalism of the Federation of State Medical Boards. She's written or co-authored 26 articles, bringing ethical analysis to public policy concerns, providing bioethics guidance to legislatures and working groups on a large number of issues, including the 2010 revision of the Georgia Informed Consent Law, which I'm particularly interested in, and it serves on the CDC Ethics Subcommittee of the Advisory Committee to the Director. Kathy received her Master's of Divinity with a focus in religious ethics and bioethics at the Candler School of Theology, completed an internship at the National Institute of Health's Office of Bioethics, and also a fellowship in perinatal ethics through Emory School of Medicine. In short, she's a very busy lady, especially this time of pandemic, and we're grateful she's taken time to speak to all of us this morning.
Thanks so much, Jan. Let me make sure you can hear me. Yep, I think my mic is on, I believe. I really appreciate the opportunity to come and speak with you all, and it's even more fun when I see all of the faces who are here, many of whom I do know, and I'm grateful to you for joining us today. It has been, of course, a very unusual last 8 months or so for all of us, and COVID-19, but also issues related to racial injustice and many of the racial concerns and social concerns that have led to protests has been sort of a second pandemic of sorts during this time. So, as Jan just said, I have spent a good bit of my time in the last 8 months really working and focusing on issues related to COVID-19, but I've also spent a lot of time over the last 10 to 15 years really working in public health ethics in addition to my original arena, which is close to clinical ethics, working with patients at the bedside, healthcare professionals who are trying to work with folks on making difficult decisions. And I continue to do that sort of apace in my role at Emory Healthcare as well. But today our focus will then be a little bit on sort of a history of pandemic ethics, and then of course a more concentrated focus on COVID-19. And so I want to, in doing so, look a little bit at kind of the early days of COVID-19 and what was happening during that time. We'll of course talk about ethical issues throughout, with a particular focus in the latter part of my talk on allocation of resources, which is again a place I've spent a lot of time. I find this graphic, by the way, very interesting. I don't know if these little fuzzy balls are an interesting depiction, but beginning to show some comparison about the types of pandemics that we've had in history and the size of the impact of those. So you can see at the bottom how the bubonic plague or the Black Plague has compared to others along the way. And at the time this graphic was created, way down here at the very bottom of the bigger runway, if you will, was the coronavirus. It's a little bit larger now. All right, do you see a slide that has a runway of fuzzy balls?
Yes.
On the right side? Great, thank you. All right, please do break in. And again, if there's something that you really want to make sure you interrupt me for to talk about later or something, feel free to do that. I'm very open to that as well. We're just going to try to preserve most of our dialogue toward the end. So again, if you look at the slide more closely, you'll see at the bottom of the slide the impact in terms of case numbers and impact in terms of the death rate of different pandemics throughout the years. And this little area down here, which is at the end of the runway, is the coronavirus. And again, it's probably a little bit larger at this point, but it's still a dot in time as compared with some of the more major pandemics in the past. So let's talk a little bit about that, sort of where we've come from along the way here. Oops, I think I went one step forward. So don't worry, I'm not going to go back 10,000 years and stay there and take you through the next 4 hours of this, but I think it is of note that, disease spread is a fascinating history in and of itself. And if we look sort of in ancient ways at the move of individuals from sort of being hunter-gatherers to gathering more to agrarian communities, then we began to see that was a place at which people gathering together and working together in fields and growing crops led to the spread of many diseases: malaria, TB, leprosy, influenza, smallpox, etc. And so again, that we're mirroring, right? The closer we are together, the more we're seeing the spread of disease in modern as well as ancient times. Also of note is pandemics throughout the centuries have not been well understood. And so Hansen's disease, or leprosy, actually was thought to be a punishment from God, leading to ostracization of individuals with leprosy. And again, people trying to make sense of what disease is and how it is spread, I think still has some interesting implications for pandemics in the modern era as well. So just so we're all on the same basis, quick definition of epidemic and pandemic, and this is from the World Health Organization. So we think of an epidemic as an increase, often sudden, in the number of cases of a disease above what is normally expected in a particular community or population, right? But a pandemic is a worldwide epidemic, usually occurring over a wide geographic area and generally accepted to include the crossing then of international boundaries and affecting a large number of individuals, right? So in order to fall within this arena, you would think about crossing boundaries. And in fact, it really is often characterized by the spread, worldwide spread at sort of at the same time. So in other words, spreading across the Canadian boundary from the United States generally would not describe what a pandemic is. It is throughout the world, you're seeing concurrent spreading of the disease. And transmission has really affected a lot of our social societies and our civilizations throughout history. We certainly are familiar with the bubonic plague, the Black Plague, sometimes it's called, that reared its head in about 1350 and then continued to spread. So the graph at the right actually shows you a reoccurrence of the Black Plague in London in the 1600s. So Black Plague did not come and go. It stayed around like many of our pandemics do. Many of our diseases do. And then as the Spanish traveled to the New World in 1492, it actually brought a lot of these diseases to the Caribbean. Was brought not only the plague, but smallpox, measles. Indigenous people were affected and led to, as approximated in several sites I've seen, the death of some 56 million Native Americans in the 16th and 17th century, again, largely from diseases that were spread. And you'll see this depiction in the bottom right corner of the people coming and, again, spreading disease to people who had no immunity against these diseases. Another area of great transmission was in cholera. And then we don't always immediately think about HIV as a pandemic, but it certainly has been a powerful pandemic that has spread worldwide and continues to affect all of us throughout the world internationally. The one area that I think we've spent a lot of time thinking about in terms of influenza, rather pandemics and pandemic ethics, has been related to influenza. And influenza sort of is an every year event for us now. So influenza occurs annually, as we all know, and many of us get our flu shots. About 200,000 Americans are hospitalized for flu-related complications on an annual basis. And the CDC has tracked, of course, US deaths every year. And so over the last 10 years, At least about 12,000 people have died, and up to 61,000 people have died from flu-related deaths in the United States on an annual basis. The annual flu in general puts particular populations at risk. So young children are usually susceptible, people over age 65, sometimes pregnant women, and then people with certain underlying medical conditions. Interestingly, many of the similar conditions that we see threatening folks with underlying conditions in COVID-19, so heart disease, diabetes, et cetera. So the annual flu is very present, and we live with it, don't we? So one thing that is interesting to think about as we're all in the midst of COVID-19 is what would it look like perhaps to reach a point where we're all continuing to live with COVID-19, but perhaps with it in a different managed state, such as flu has been. I'm going to mention a few of the key influenza-related pandemics that, again, you may be familiar with, but it's fascinating, a fascinating history. So one of the ones that had the most impact in terms of death causation is the 1918 flu, which was a H1N1 variation of the flu, sometimes referred to as the Spanish flu pandemic. It actually affected, and again, it's interesting, the range here in 1918, we weren't tracking things quite as successfully, but different studies have reported between 20 to 40% of the worldwide population actually got the H1N1 Spanish flu, and 20 to 50 million people actually died, with 675,000 deaths just in the United States alone. The attack rate and the death rate was actually highest among adults in the young to middle ages, so 20 to 50 years old, which is very unusual for influenza viruses. So part of that influence came from the fact that we were at war, and so wartime troop movement spread the virus very effectively. The second wave, and again, we've all been talking about, are we going to have a surge? Are we going to have a second wave of COVID-19? Maybe we're in the surge, maybe we're in the second wave. Second waves of viruses is a classic descriptor of viruses. So the second wave in 1918 led to a fall wave again during the fall season with a possible mutilated virus, which led to increased deaths and a little bit of a shift in the nature of who was affected by that. And of course, microscopes were not invented until the 1930s, so there was no way to identify virus, and therefore no vaccine available. So interesting sort of mirroring of the time. The W curve at the bottom of your screen is to indicate that this is considered kind of a W curve virus. It affected both younger populations, which is typical of influenza, so that's your left part of the W. The middle is the unusual part, where we again had young adults and middle-aged folks who were affected, and that's unusual, and then older people, people over age 65 who were affected. So a little bit unusual nature of that particular influenza. The number of deaths in the United States, again, was significant. The number of U.S. servicemen killed in any war, you can see listed at the bottom, and the 1918-19 influenza killed more people than any war that we have had. So significant, really huge impact on the population. This is a picture you may have seen before of Camp Funston in Kansas. So there was a county named Haskell County in Kansas where we believe, it's not, no one agrees completely, but there's a good chance that this may have been the beginning of the 1918 Spanish flu. And in this case, that was a migratory route for birds, about 17 species of birds. And also that was a community that was heavily involved in the raising of hogs. And so the question of whether some interspecies kinds of creation of the virus occurred, transmitted to humans. And again, we saw the beginning of a small outbreak at first in Haskell County, which was reported to the public health departments. And then a few of the men from Haskell County went to Camp Funston to be a part of the war effort. And on, I think, March 4th, 1918, there was a first diagnosis, and 2 weeks later, 1,100 men at Camp Funston were in the hospital with this new virus that was, of course, still unknown. And so things spread rapidly. These men often then went to other camps around the United States, so the virus spread that way. And of course, there were people getting on, military folks getting on ships going across the ocean with continued transmission abroad. And in fact, a number of people dying in the transit across the ocean to go join the war effort. So it's a fascinating history to think about, and powerful how the conveyance of the virus probably occurred, as we can see in the close beds, even here within their emergency hospital setup. Now, if we thought we were alone in wearing masks, I just want you to know we were not. So this is in 1918, 1919. You can see not only were military folks wearing them, exhortations to wear a mask from the public health, in this case, the Red Cross, but you see families were adopting the practice, and even some animals you can see here. Somehow they got their cat to put on a mask. I'm not sure how they did that, but so masks were a part of the everyday activity, just as we are dealing with at this point. If you notice in the wear a mask notice from the Red Cross, I find this interesting. They're basically exhorting us to say that doctors and nurses are not available in adequate numbers to be able to take care. So please wear a mask, right? They also claim that a gauze mask is 99% proof effective against influenza. I'm not sure that was the case, but in any case, that was a part of their everyday as well, just as it's becoming everyday and has become everyday worldwide. So Berlin in the top left corner and around the world, we're seeing what we're all dealing with, and at least in many places where masks are common. Masks, of course, bring up one of a central issue ethically in terms of pandemics, and that is a question of balancing individual liberty with community interests. And I believe this is a huge issue for all of us, right? Both ethically, but also we're seeing some political overlay here and questions of what people are willing to do. So even with the questions around this, there really is a moral tradition in the United States that it could be acceptable ethically, or maybe even mandatory at times, to suspend ordinary moral rules when a community is threatened. So if our very functioning of society is threatened at times, we have to restrict what we would be able to do on a regular basis. And of course, we think about this in the larger venue of what we do every day. I mean, we have speed limits on our expressways that are not always completely abided by, but in general do constrain, I think, many people to drive safely so that others are protected and they themselves are protected. So we see this idea of balancing individual and community interests every day, but certainly there are times where it becomes even more important to put forth the idea of constraints. So as we think about what is a legitimate restriction on individual liberty, well, there may be limits that are important when we follow certain sort of rules or aspects. And one would be, when we're not doing this just quickly, all right, we're very cautious and thoughtful about when we want to institute something, that it's really at the point at which it's important that we ask each of us to restrict our individual freedom, and only when alternative approaches are not likely to be effective. So this idea of physical distancing, some people call social distancing, limiting our ability to be out, mask, washing our hands, all of these things would be proven, if you will, approaches that would be reasonable if they are likely to be effective. And that we do try, and this has been hard, frankly, in COVID-19, to anticipate what conditions might call for an infringement on individual rights. I say it's been difficult because everything hit us, right? And late February, early March, we began hearing about this. There was not a lot of time before we were all reacting and kind of almost overwhelmed by what seemed to be happening in our own communities as well as around the country and the world. So these would be good principles, if you will, to follow in terms of when is it reasonable to begin to think about limiting individual rights. And so we think about in ethics 3 sort of general principles. One would be that you would adopt the least restrictive practice that would accomplish your goal. Don't go out of bounds. What will actually work? If we don't know that, we should be cautious about intruding too much in liberty until we know that certain things are effective. And again, that's been a bit of an interesting principle for us, right? In this COVID-19 environment, we weren't sure. And so there was a lot of confusion, particularly in early months, about what we were being asked to do. And that led to, I think, some question for many people about, well, gosh, do we wear a mask? Do we not wear a mask? You can't wear an N95. Are these other masks effective? So there was a lot of confusion about what was the least restrictive practice that would be effective in this environment. It should also be something that's necessary and proportional to the need for protection. And I think we have a lot of people in our society in the United States who still don't feel that this has been accomplished, right? Who do feel that this has been out of proportion, or that the virus has not required all of these interventions. Many other people believe that it does, but there's been this discussion about that. And then when we have restrictions, then we need to work to ensure that those who are impacted by the restrictions receive support from the community. And that can be in a variety of ways. I'm thinking about all of the people who are now trying to work from home and perhaps in jobs that make it difficult to work from home. What are we doing to support those folks? There are many organizations that have continued to hire people or to maintain jobs, even when those jobs are really are difficult to actually do from home. And then, of course, there are many other people who don't even have the luxury of working from home, and whose livelihood is threatened, or their lives are at risk because they're going in to environments where risk of transmission is great. So, but there are things that we can do, right? We can make sure people are taken care of, that some of their basic needs are taken care of, that try to ensure that people are not terribly affected in the long term by restrictions. But these are 3 sort of principles that we often use in a lot of ways in public health ethics and beyond that I think are important to think about. And then, of course, we all look at the gathering. So this is in 1918 at the end of World War I, where despite the fact that there was a mandate for masks and a bit of a ban on gathering, that did not work. And so we're challenged by the same issue today, right? People are having trouble sort of staying in places where they can be appropriately physically distanced. And we know that in many of the parades related to the ending of World War I, there was further transmission of the virus at that time. So again, just to mention a couple of more influenza viruses, because it puts a bit our COVID-19 situation in perspective. Another very well-known virus was the 1957 virus, again, a slightly different strain, H2N2, sometimes called the Asian flu. Putting things in print in quotes, because I think we have seen even now with COVID-19 some concerns about the way in which flus are named or labeled, and what kinds of potential for stigmatization or discrimination can occur in doing so. But again, I'm giving you historically, this particular flu was called the Asian flu. It was a different kind of flu. It had a number of small outbreaks over a summer in 1957. And here the flu really hit school children, young adults, and pregnant women. And among the elderly who were hit, they had the highest rates of death, but the prevalence was higher in younger folks. There was a second wave of infection again. So again, we see different pandemics in the past with waves. There were about 1.1 million people affected globally. And again, a bit of a range, but from about 70 to 100,000 people in the United States died from this particular 1957 flu. 1968, we had an H3N2, sometimes called the Hong Kong flu. Here we see that the virus began to shift, right? So we have an antigen shift in this virus. Things begin to change in the nature of the virus itself. had sporadic impact in areas of the world because some people had some immunity from prior into viruses. Again, two waves, significant amount of deaths globally with about 1 million people dying, high illness and death rates in the United States. And there, again, sequentially, we could follow through a number of other viruses. So just, again, influenza viruses, you see the continued progression, and it will be interesting to see what happens with COVID-19 as we move forward. We also had, by the way, you remember the SARS, some of you, acute respiratory distress syndrome in 2002. It was, by the way, a related coronavirus like the COVID-19. The impact was much less in terms of number of people affected, but it was fairly deadly. Its case mortality rate was very high. And again, we watched how coronaviruses can infect animals, evolve, and be transmitted to humans. The horseshoe bat was believed to be the source in what they call wet markets, where live animals were sold for food. And at that time, no diagnostics, no vaccine, no therapeutic treatment was available at the outbreak. So some similarities a little bit with the COVID-19. You can see the H1N1 2009, which is the last really large influenza virus that we have a lot of history and sort of connection on that I'll mention. So it's an H1N1, transmission occurred across the United States, and you can see a sort of a pattern of spread here. And in this case, there were 60 million people in the United States who contracted this H1N1 swine flu virus, leading to about 12,000 deaths in the United States, so not quite as virulent in terms of the case fatality ratio, but many people died worldwide. There was also, again, a fall wave, which is what we believe we're experiencing now. The overall mortality rate was about a 0.02%. I think there's a lot of variation, and when you hear case mortality rates or case fatality rates, CFR, to be very careful about that. One of the most recent ones I've seen about the United States is probably about 2.6% with COVID-19, but we have to be thoughtful about what that actually means. So it's defined as the number of confirmed cases over the number of confirmed deaths. And if we don't have good data tracking of actual infections, we don't have adequate testing, then you can see how the case fatality rate can get altered. But my point here is that this is a fairly low 0.02% case fatality rate. So the impact in terms of death was much less than what we're seeing in COVID-19. And by the way, another word or phrase you may have heard is the R naught factor, that R with a zero after it. That means the number of people who will be infected by one person with the disease. And so again, we watch that in swine flu as well as in COVID-19, of course. So now let's move to COVID-19 a little bit. So there are some differences if we think about that and compare it with the H1N1 2009-2010 pandemic. COVID-19 is much deadlier, especially for elderly folks over 65, they say, and those with chronic health and lung conditions and diabetes. And now we know there's actually a few other possible underlying conditions that may put people at risk. Again, the R naught factor is between 2 and 3. So that means, again, if I had the disease, I'm likely to give it to between 2 and 3 other people. So it spreads more rapidly. There's greater economic and social disruption caused by COVID-19. And really, though, there weren't as many efforts with H1N1 to actually look at physical distancing and other non-pharmaceutical interventions. So there is a shift here with COVID-19. COVID-19 too, even though we've had other coronavirus strains, this is a completely new disease, right? So a vaccine has to be developed, as we know, and tested essentially from scratch. And we're seeing that with an enormous number of vaccine manufacturers entering the fray months ago, and now distilling itself to a smaller group of vaccine manufacturers for whom the research is continuing and perhaps looks promising. The improvement over the last 11 years between the 2009-2010 H1N1 and the current state is significant, right? So there's increased capacity of programs to deliver vaccines to those who need them. Again, we got to have one first, or more than one first, but at least there is an increased capacity. So there are some significant differences. We continue to learn about viruses. And interesting to watch the terminology. So I don't know if this caught you, but it was interesting early on how the virus was being referred to. So is this is a coronavirus? Well, yes, it's a type of coronavirus. It's COVID-19, okay? Or is it the SARS-CoV-2, and which is the severe acute respiratory syndrome coronavirus 2. So there's been many different ways of referring to this. Again, interesting to watch our language and terminology. By the way, with the H1N1 in 2009, this was all the projections that we would have a pandemic that would occur at some point in the near future. And this, again, their predictions that would result in between 2 and 7.4 million deaths globally. This was a WHO specific projection, that we would have a scarcity of resources, that medical facilities would be overwhelmed, that there would be a shortage of personnel and services throughout the entire community, and a lack of vaccine availability, modeling predictions that the pandemic is coming. And so in 2009, 2010, I was involved in this. There was actually a lot of preparedness efforts going on. States, including the state of Georgia, had a crisis standards of care process, so developing a statewide plan. We actually did the ethics framework for that. We went to regions throughout Georgia and actually did presentations and worked with healthcare systems on adopting crisis standards of care. So a lot of work was going on, again, given the idea that, as we were all hearing, it's not a matter of if, it's a matter of when the pandemic would occur. And interestingly, then things went relatively quiet. The preparedness efforts kind of halted in most places. Though states often have crisis standards of care plans, nothing further occurred. Institutions sort of put them in their side pocket. I think a lot of healthcare systems have them, but are not actually utilizing them fully at this point. So it's interesting that the lull of the last 10 years or so has perhaps been problematic in terms of our being able to keep being prepared and to actually have been prepared for the COVID-19 pandemic. We know that the virus seems to have originated in Wuhan, China. And this is an interesting graph. So it indicates to the far left that in December of 2019, there was some awareness of changes in cases. And so there were some efforts by the government to do some tracing. But then a real clear detection occurring in January in one Shanghai lab of the coronavirus. It seemed to be, similar to SARS. So again, early on, Wuhan was placed under quarantine toward the end of January, and then we see the explosion, if you will, of cases through this time and of deaths through this time. Of course, one of the powerful realities in this case is a story, a narrative about, I'm not sure I could say his name correctly, so someone can correct me later, Dr. Li Wenliang, who is an ophthalmologist in Wuhan at a major hospital there. And he is now kind of thought of as the whistleblower. So in December, December of 2019, he began just communicating informally with medical colleagues through something like Instagram, WeChat, was a diagnostic report that had identified a new illness that looked like a severe acute respiratory syndrome. So he's just informally saying, hey, we're beginning to see reports of something unusual going on. And his colleagues were interested. There was a lot of sort of traffic back and forth trying to understand about this. And so as that activity began to spread in terms of communication between medical providers, authorities actually reprimanded Dr. Wenliang for spreading lies and stopped his activity and began to sort of punish people for continuing to discuss this. And again, it's a long and rich story, but very sadly, this physician contracted the virus himself and died early in February, on February 7th. And it took the region communities a while to protest what the government had done in silencing him and others. And in fact, he has been declared a martyr, which is a very high honor in China. So there has been some interesting movement within that particular region in China and within, I think, the country as a whole, to understand that provision of information and early opportunities to have identified and perhaps mitigated this disease were missed. But it's a powerful part of the story of COVID-19. And now, and this was just this morning, I took a quick snapshot. If you're not familiar with this site, it's a very interesting one. It's a dashboard of COVID-19 by Johns Hopkins. And in fact, if you just Google Johns Hopkins COVID-19 Dashboard, this will pop up. It has several menu items. In addition to the map I'm showing you, it has a snapshot of active cases, and other sort of aspects that may be of interest to you. It's really powerful to look at. And I had a couple of snapshots earlier in the pandemic where you see the dramatic increase. So globally, there are about 43 million cases as of now, and over 8 million, of course, in the United States alone. Again, I'm looking at this area on your far left of the screen. And then global deaths are recorded over toward the right, 1.15 million deaths globally now in the United States, over 220,000 deaths at this point. You can also see the daily case rate on the bottom right in the gold increasing over time with a bit of a spike toward the end of October, maybe a slight drop here. But the reality is we have seen an enormous spread of this virus with significant impact, both in terms of morbidity, I mean, the illness levels of individuals, and mortality. And this is an assessment prior to COVID-19 of the readiness of various countries to deal with a global pandemic. So it's something called the Global Health Security Index. And you can see who is at the very top, meaning we were supposed to be in the United States very well prepared for this. And factors you can see toward the right-hand side include that we had significant investments in prevention, in detecting and reporting. We had a rapid response system, a health system compliant, rapid response health system. We had compliance with global norms. We had a risk environment that was attentive to these kinds of issues. So they rank all countries in the world, and we're at the very top for being prepared. And yet we have not been very effective as compared to many other countries in the world, both developed and countries, developing countries, as well as developed countries. So it's fascinating to think about what has gone wrong in terms of our readiness or preparedness. And as we think about comparing or looking at the factors that influence COVID-19 spread, we have to think about, of course, the route of transmission, which has been primarily respiratory, but also the ease and the rapidity of the spread, the kinds of symptoms that the different viruses have, who is most likely to contract the virus, who's most susceptible, what kinds of severeness of illness factors are there, right? So what kinds of hospitalizations, ICU admissions, as well as deaths have occurred, mortality rate as well. So as we think about different viruses, these are good categories for comparison. So now I'm going to switch a little bit, let me check my time too, to an area where I've spent probably the majority of my time with healthcare systems working on allocation ethics. And I'll try to keep this somewhat brief because I really do want to move to being interactive with you. In about mid-March, early to mid-March, I got a phone call from some of the leadership at Emory Healthcare saying, we need to put together a allocation plan should we reach a point where we simply don't have adequate resources for the patients coming into the Emory Healthcare system. I also, as Jan mentioned, work with a network of healthcare institutions in the Southeast, primarily in Georgia, but we have some outside of Georgia as well. And I was beginning to get lots of communication from them as well to say, how do we go about thinking about this in our healthcare system? And so we began sort of working apace on an allocation process. So think about how we currently utilize critical care resources. And there I'm thinking about, for example, ICU beds or ventilators or other critical care resources. So CCR is my abbreviation for critical care resources. Let's compare what happens during routine conventional times, so non-COVID times. So in routine clinical care, the patient comes into the emergency room. We're going, and we have beds available, we are going to admit them. And if they need to go to the ICU, they'll be in the ICU. And by and large, if treatment is continuing to be reasonably successful, that patient is going to continue to be able to let the clinical team know, yes, I want to press forward. And so we're respecting of the patient's autonomy, of their informed decision-making. We're pretty much going to leave them in the ICU for continued benefit as long as possible. In a public health emergency, which was what was declared in Georgia, right? We may not be able to honor patients' preferences all the time because we're in a situation where we have scarcity of resources. So this is a huge shift, right? From I'm going to pretty much respect what my patient's preferences are to a degree. I mean, there comes a point where, you know, and again, away from viruses, where if we have a patient who is continuing treatment that does not seem to make any difference for the patient, it's not beneficial or effective, then we might begin conversations about stopping that treatment. But if, again, there are opportunities we see for continuing the patient, even for weeks or months, sometimes in the ICU, that happens in routine care. But in a public health emergency, we began having to think about the scarcity of resources and therefore whether we can continue to keep a patient in the ICU for a long term. And so again, in conventional routine usage, non-COVID times, our goal is to minimize bad outcomes, including morbidity, illness, right, and death. And so again, as I said, it's kind of first come, first served. We're going to take whoever appears in the emergency room. As long as we have ICU bed availability, they're going to come in. And once they're receiving a critical care resource, we're going to continue it. We're not just going to talk about removing it in any way. In a public health emergency, scarcity has become unavoidable. We really are at the point we're talking about where difficult choices have to be made. And by the way, very important, I've put a bullet in here about preventive action. Everything possible needs to have been done and need to continue to be done to build adequate capacity before a pandemic, during the upswing of a pandemic, you know, going to those stockpiles of ventilators, whatever needs to be done. And let me tell you, it's really remarkable to me when I look back over the last 8 months, how successful most places, at least in this country, have been in avoiding getting to the point of absolute lack of resources and having to make tragic choices. So ICU units expanded, took over more and more units within many healthcare systems, and were able to do what they could to make sure that capacity expanded and we didn't get to the point where there just were no more particular critical care resources for patients. So prevention is really important, but allocation plans plan for the point at which, despite all your efforts, you now have 4 people on the floor who need to come to the ICU, or 3 people in the emergency room and 2 people on the floor, and we don't have an ICU bed available. We don't have a ventilator. We don't have other critical care resources. And now some type of decision will have to be made because not everyone can receive them. And so much of the efforts have been related to prioritizing those who are clinically felt to most likely benefit. So what does that mean? How do we maximize the number of lives saved? Many of the processes have looked at two primary criteria. One is just the likelihood that we can actually help the person survive this hospital stay. So survival to discharge, again, based on clinical criteria. And a second criteria has been the idea of, can we increase the expected number of what's called life years saved? We're going to try to maximize the years that people will then get to live once they have survived their stay in the hospital. And again, this is not based on age. It's based on clinical criteria and looking at what the underlying conditions a patient may have. What would we predict the chances are that this person will be alive in 1 year or 5 years? And many institutions are looking at this as a potential criteria for decision-making in addition to, again, simply surviving the hospitalization. Another area that's been talked about, and we've all seen this, I think, in the news as well, but it's been very important in the allocation plans themselves is, should there be certain categories of people who should receive the resources? One of those has been healthcare professionals have very much been in the conversation, and something that we sometimes term a multiplier effect, that the physician or nurse or respiratory therapist getting the critical care resource, should they become ill, would then be able to improve and go back to providing the care for others. So it will multiply the effect to take care of others for that healthcare professional, perhaps to receive a critical care resource. If we think about that, do we want to move beyond physicians, nurses, respiratory therapists, maybe to all healthcare workers who are in a hospital system and who may be at risk of increased transmission? And then we have to move beyond the healthcare environment, right? We've all talked about essential workers. So we can think about in healthcare, the person who transport patients or people who come into the room to make sure the rooms are sanitized. But then we also think about how much we're dependent upon our grocery store employees who make it possible for all of us to have adequate food, or delivery persons. So how do we think about essential workers? And would we, as a community, if we were the community, would we all say, I think it's important that we prioritize some of these categories of essential workers in who actually gets critical care resources? There have also been powerful conversations about making sure that people who are individuals living with certain disabilities are not discriminated against in making these calculations. And there were complaints to the Department of Health and Human Services Office of Civil Rights about certain statewide plans that led to changes in those plans to try to minimize the chance that discrimination would occur in any way for individuals living with disability and other groups as well. The intersection I mentioned at the very beginning about racial injustice and underlying kind of health conditions that may be resulting from underlying racial injustice, foundational sort of systemic issues, have also raised the question of whether there are vulnerable people in our society for whom they are thought about as disposable, if you will, as this particular article names them. So again, how about individuals who don't have the luxury of working remotely, who must take mass transit to work because they have to continue to afford support for their family food and housing for their full family? They don't have the luxury of that. They have trouble, therefore, socially distancing at work, and maybe as they travel back and forth to work. They're already dealing with income inequity, and again, may have many underlying conditions as a result of underlying inequity in terms of where they've been able to work, or how they are, the conditions under which they currently live and work. So, how do we think about that? Do we in some way change our allocation plans to reflect some additional benefit for individuals who are living with these structural inequities, even prior to the epidemic, has been a huge part of the conversation. And then I'll end with, I happen to be on the CDC Advisory Committee for Immunization Practice for COVID-19. And all that means is we are charged with making recommendations about what the allocation tiers will be, like who will first receive the vaccine, because we anticipate whenever vaccines or vaccines are available, there's going to be a period of time where we don't have enough vaccine for everyone. Hopefully it will ramp up and we'll get to the point where there's enough vaccine for everyone. But what do we do in that interim period where we have to choose who gets the initial doses of vaccine? And so here again, in terms of vaccine choices, we're in a preventive phase again about maximizing preparedness. So we're thinking, everybody's thinking about distribution pathways, who will distribute it, where are the sites at which vaccines will be able to be delivered. Some of the vaccines we're hearing about publicly are ones that require certain storage conditions, like ultra cold storage conditions. And once you open the vaccine package, how long will it be good under certain cold conditions? So there are many things that will impact. So how do we plan for all of this and try to maximize preparedness? One of the things I have been very concerned about, and it's a time factor, is there's been very little public engagement around how to do this well. So often in ethics, we do public engagement or community engagement exercises where we try to bring in representatives from populations who will be most affected so that we listen. We're trying to include that in the planning process. And there's been very little of that, just given the rapidity of the spread of COVID-19. So, and here again, we're still about, how do we go about maximizing benefits and minimizing any harm? And of course, that's been a big conversation in the vaccine production. Is our production schedule going to be as safe and secure as it is under the production schedule of other prior vaccines? Has been a real concern because there's a lot of pressure to move forward with getting a vaccine. So we need to make sure we're not putting ourselves in a place where vaccines would be approved without being safe and effective. So how do we minimize any harm potential there? That the process needs to be transparent and fair. So that's a big part in ethics. We talk about the procedural justice or procedural fairness in addition to what's the answer that we come up with in terms of, for example, which tiers will go first. And then we think about fair and just stewardship and distribution of the vaccines themselves. So all of these things are being thought about. There are certain things we don't want to sort of put forward. There are certain things that are generally felt to be ethically not reasonable. So things that would be things we would see under the law as being discriminatory. So considerations that would lead to discrimination based on age or race or ethnicity, et cetera. In general, we don't really want to maximize or prioritize individuals based on somebody's social worth or status. An interesting little twist to this is if we do think there are people by virtue of their profession or their occupation who ought to be prioritized because their worth as multipliers, like healthcare professionals, or their public health officials responsible for vaccine production, should they be given a little bit of a social worth recognition because of their placement within society? Controversial, right? And then first come, first served, right? So that is not considered to be in distribution of vaccines a reasonable ethical option like it is in some other areas in medical ethics, because those who have less information or who have inadequate transportation or less access may never get to those sites, right? So the idea of, well, let's just, open up all of our vaccine sites and whoever gets there first gets it and that's it, is not considered to be ethically reasonable. There are a lot of potential vaccine groups, those that are high risk, and we think about those again with underlying conditions, There's been a lot of attention paid to people who are living in congregate settings like nursing homes, long-term care facilities, people age 65 and older, again, partly related to the underlying conditions increase in that group, people who are homeless, people who are in prisons, and others in other institutional or congregate settings. And then we think about children who traditionally are fairly highly listed in terms of vaccines in prior pandemics. But of course, children maybe thankfully have not been as affected by COVID-19 as other viruses as well. And then we've mentioned healthcare providers, right? How do we think about other potential vaccine groups? Direct healthcare providers, other essential workers, again, those people who are delivering packages to our door every day or helping us at the grocery store, et cetera. How about individuals disproportionately affected by existing inequalities or inequities? And those whose vaccination in itself might help others, so personnel in nursing homes, those who are working in prisons, and even people thought about school-aged children because there's been such a return to school environment in many communities. And the children may be relatively protected, but may bring home a virus to someone as well. So a lot of different potential criteria here. Again, we've talked about minimization of death and serious complications of illness as one of those. But we also think about preserving the functioning of society, right? What do we need to make sure that we have continuing providers who can care for us, continuing public health officials who can make sure that decisions are made in ways that are good and fair? How do we think about that? So there's lots of criteria under discussion. And again, they mirror many of the things we talked about with critical care resources, but this is in a preventive mode, if you will, with vaccination. All right, so I think I'm going to stop there. These are just some other general ethical condition or considerations. Again, who decides? Procedural ethics again. How much do we have the community involved? How do we think about cultural differences and humility about that? Special considerations, again, about those living with health disparities. Do we want to take that into account? If you all were the ACIP CDC work group, would you want that to be a priority in how you thought about who gets a vaccine? How do we think about global efforts? We keep talking in the United States about United States distribution. Do we have some obligations to work with other communities around the world? And how much do you want this coming from the federal level versus your more local state or community jurisdictions having some leeway to make decisions? So I think I'll stop with that because I think I've talked a long time and look forward to communication with you.
Terrific presentation, and it clarified some things and raised all kinds of other questions, of course. And one of the things that I've found so fascinating about this whole issue with the pandemic preparedness is we never thought that we would have a president who would refuse to wear a mask, and that it would become so politicized. And the first thing that I've thought about was, yes, you can prioritize things any way you want, but what if you have people who will not take the vaccine, who are afraid to take the vaccine, and you almost want to prioritize anybody that'll take it, make it first come, first served, just so you can get some people out there taking it, saying, yes, this is a good idea. But it's really quite shocking how the political nature of this whole thing has complicated all of it.
Yeah, thanks. Great comment. And again, there's probably a diversity of opinions about politics on with us today. So, but I do think there's some power in role modeling at the highest levels from our leadership throughout. And so it has been an interesting addition to the question of how we proceed with caring for people during COVID-19, not to have some people modeling that more effectively. Yeah, so I think that's a difficult part of this. And then to your second point, It is, it's of note. So even with the vaccine the H1N1 vaccine, there once tiers were created, there was a lack of uptake in some of the earlier tiers that were identified. And so we were in a very, I think, unfortunate position in terms of actual distribution, where people were asked to come in certain categories, and we had unused vaccine for a stretch. That gets to a little bit of this preparedness issue, right? What can we be doing now to think about how would we react to that? I also will say that some of the groups that have been discussed just nationally about potential prioritization, we're also hearing or saying, I'm not sure I feel that this is a safe vaccine, or we don't even know yet, right? But I'm not sure that in the first wave of vaccination, I'm going to feel that I have enough information to want to get that. So there are concerns. And then there are, at least for some communities who feel that historically they are at risk of being used, that they're unwilling to consider that, you know, they would take the vaccine. So we in some of the conversations nationally in the CDC, ACIP, and in other, the National Academies conversations, we're hearing from communities of people who are saying, you know, historically, my race or my ethnicity has been marginalized and put at risk, and I don't want to be put into the first tier. So there are a lot of complications in terms of how do we therefore create a fair distribution system that does not hold a lot of the vaccine for, you know, months while others could benefit. So I think some tiering of how we would move, when we would move to other groups is probably an important question.
So as far as allocation is concerned, I suspect this group would probably, you know, vote for the older population being included in the early allocation. But it occurs to me that with the vaccine, there's an attitude now that, okay, we get the vaccine, we're going to have a solution. But if we think about the flu vaccine, we don't really tell our patients, okay, you get a flu vaccine and now you're protected. We say, okay, maybe you're 50% protected. Maybe your disease will not be as severe. We don't even know those things about the vaccines that are being developed. So having a vaccine available to me does not take away the public health measures that we have come to believe may be effective. And if we look at other countries, they are effective. I was in Wuhan, China last year, and I was in communication with friends in different places, including Nanjing, where they were really took very serious measures. And there are examples of public health measures controlling the epidemic, China being a good one. Some less authoritarian countries like Korea being others, Hong Kong, and so forth. So my question is, from the ethical point of view, when you get into this whole thing about the individual freedom versus collective effort, can we in democracy, Western democracies, get to this point? Because the individual freedom has almost been taken as a liberty, an entitlement. Okay, I'm entitled not to wear a mask, even though I'm imperiling my other citizens, and the freedom trumps any kind of public health measures. And, you know, in public health, freedom has to take a back seat, that kind of freedom, the freedom that imperils others. And from a societal view, do you view any optimism that we can say that our freedom may not be there for all this? I don't know if we need another amendment to the Constitution. I wrote one down: the right to restrict individual freedom that threatens others. Is that constitutional amendment that we need. That's a bit of a joke.
That's great. So I'd like to know when you'll be proposing that, Spencer. I think that's, yeah, I mean, all of your comments are really powerful. I mean, I do think we see other Western nations who have been more effective in calling for curfews. And in fact, some of the countries like Spain and France that weathered the pandemic better than we did had much more strictly enforced sanctions, if you will, and then opened up and now are, you know, restricting again, because again, they're in their second surge, if you will, or second wave. And so I think we've seen some models where that has been done and it has made a difference. In fact, if you look, I think it's the Johns Hopkins site, but there are some sites that actually show you where the curve was bent, if you will. If you look at a map, a graph rather, in every country, but the United States has not really bent that curve very much. We did somewhat, right? We did earlier, but not to subside it. And so I think there are absolutely very clear ethical reasons why asking for limitation, it's really a respect, as you've said, for the common good, for public health, for the public interest, that there are times where our individual rights are rightly limited. The problem, a bit of the problem, of course, is we are in a society that really values individualism, values individual rights and liberty. And that's a wonderful thing in general. But sometimes we won't have those individual rights and liberties unless we also see the potential for constraints. It would be good to not have to necessarily look at sort of a authoritarian philosophy to impose, but to actually build more public will around that. It's just that we're seeing at least segments of the population who are not going to be influenced, I think, by that. So would we get to a place where there would be more curfews, et cetera? It's going to take a lot of not only public will, but political will for leaders at the state and community level to say, you know, no. I have been to some communities in the last few months where I can tell that a county or a region has literally adopted everybody's wearing masks. You don't see people without masks. I've also seen areas where that's not the case. And so how do we both build public will? How do we continue our educational efforts to say, this is what will make a difference? Let me show you the proof in other countries. How do we do that? And also, I think we're going to have to get serious about the reality of restricting some of our liberties within certain communities, if not nationally, in order for a difference to be made. Back to your original point too about what we know and don't know about what vaccine will occur. There are some really important questions there. Like we take the flu shot, many of us, every year. We don't know if the strain is actually a good match that year. Sometimes it's better than others. But if you do get the flu, you may be quite ill, but many people are going to survive the flu and do relatively well. This is a different impact. There's a more of a potential for loss of life and for serious illness with COVID-19. What we don't know about the vaccines also is duration of benefit. You know, is this maybe we'll come up with a flu vaccine where every 3 months or 6 months we have to take another vaccine because we realize the duration of benefit. So there are many things we don't know. We're operating in an environment of uncertainty, which makes it difficult, I think, to know how best to proceed in a country that has ideologically valued the ability of individuals to have some input into what they're willing to do.
Oh, thank you. I guess you can hear me. As an old public health physician and former CDC epidemiologist and ACIP member, let me tell you, I loved your presentation. It's marvelous. One of the ethical considerations I've had for a long time is the question of, should you pay more attention to years of life lost or other things? And I actually have given priority often to years of life lost in terms of addressing what populations need. But if you look at years of life lost as a primary criteria, obviously us old folks, you know, we don't have very many years of life to lose. And so you get into the question even of giving vaccine, who should have the priority? And you look at people in nursing homes and us old folks, you know, we don't have so much. And I don't know how much that has been given priority for. Just another quick one here about the other countries. We should have learned from those Asian countries way back in January and February what was important in controlling the disease. It's so much important in an epidemic to get it very early so you don't have an exponential rise to that high curve. We should have known that way back and done something. And those countries, of course, they've had recent experience with SARS and et cetera, and they also had much more history of wearing masks. So
Right.
That's just my thoughts.
Yeah, no, I agree with your latter point as well. And on the years of life lost, so just one clarification, again, you all need to join me in an ethics class so we can all talk about these in depth. But so years of life lost is often really defined by if you have underlying conditions that, irregardless of the current situation, might lead one to expect they wouldn't be surprised if you say were not able to survive more than 5 years. And so it's that constellation rather than age in and of itself. Now, there are some other ethical approaches that actually look at age. They talk about a life cycle approach, that all things being equal, would it be better to give to someone who has not had a chance to live through the various ages of life? So if you took that approach, which some ethicists do, you would say, well, then somebody in there who's 14 or 20 should get a vaccine prior to someone who's lived through most of the ages of their life. But it's pretty controversial. So that is not, the life cycle approach is generally not adopted by most people working in the pandemic ethics arena. It could be maybe, you know, if you had more people who were in need of, say, a critical care resource, and you went through other categories and you still had too many people, you could, some people say, get to a life cycle approach, but that's generally not the way people think about it. But they do think about, you know, like I said, if we're in a hospital, we're talking about a critical care resource, and we expect that this patient has a good chance of surviving till discharge, right? So that's the first hurdle. And that the next thing would be, and is this a person who would likely have many years of life left? And that means I could be 70 and expected to have many years of life left because I don't have any significant underlying conditions. I could be 20 and have significant underlying conditions, and my life would be limited, expected to be limited, and I would have less of a chance as a 20-year-old than the 70 or the 80 or the whatever year old to get a resource. So just a clarification there that age is generally not respected. And in fact, some of the complaints to the Office of Civil Rights were based on age discrimination that seemed to be allowable in some of the statewide plans around the country, and those have been eliminated. So just a clarification there.
Thank you.
John is next.
John,
Hi,
thanks.
Kathy. John
Hi.
McCowan. That
Hi.
was a wonderful exposition. In Utah, the situation has gotten such now that the Utah Hospital Association to invoke their plan, which gives priority to young people and pregnant women. How does that compare with the Georgia priority list?
Great question. So first of all, Georgia has not come up with a statewide plan. The leaders in the state level, and there's been conversations at public health as well as a government sort of level, have not wanted to move forward with declaration of crisis standards of care, nor with developing a clear plan. So right now in Georgia, it's really up to individual healthcare systems. And that's concerning in terms of consistency, right? Standardization. I will say, and this is a slightly good vein, because we have a lot of institutions who are in our healthcare ethics consortium. We're all in conversation and have been since March, and have in large measure done a lot of consistency building across institutions. So that's one slightly good news. But I would say that what you're telling me about Utah was somewhat unusual. So again, the idea that because of the prevalence of the impact of COVID-19 in different groups in the United States, that just choosing those as your 2 priority groups is somewhat unusual in the way I've looked at other state plans. And again, we're still finalizing what the ACIP will come up with. There have been some really good reports, as you probably know, John, in the last month from the national academies. John Hopkins had an interesting report. WHO has a SAGE experts report. And they're looking at, again, some of the major groups I mentioned, whether it's high-risk individuals, yes, right? But within that, are we talking over age 65? Are we talking about particular populations? But also the questions of, what do we do about healthcare providers? Should they get a priority, or healthcare workers at large? So it's interesting to hear what Utah's doing. I'll look it up. I've spent some time earlier in the pandemic actually collecting a lot of the state plans. And I'm going to be doing some research this year with some funding from the Health Sciences Center to actually explore healthcare system-based plans and how healthcare providers feel about potential implementation of those plans. And so
We'll look forward to it.
Oh, good. Thanks, John. By the way, if Utah's triggered it, I'll be curious to know more. They haven't had to yet, John?
They haven't triggered it. Hospital associations asking the governor, but nothing has happened yet.
The only place that I'm pretty much every other Monday, I am on a conversation with bioethics program directors from the United States and some from Canada. And so we're trying to keep very much up to date. The one place that I've heard, and this has been in the public news as well, has been in South Texas near the border, where there are some vulnerable populations, particularly there, where the ERs and hospitals have been a bit overrun. And at least from local reports, it sounds like some healthcare systems have had to make some tragic choices. But otherwise, in terms of formal recognition that we're now in crisis standards of care and choices are being made, I'm not hearing that yet.
Thank you.
Denise is next.
Denise?
As you were talking about plans for prioritization of resource allocation in hospitals when they're becoming overwhelmed, it seems like you have this ethical framework, but it doesn't, that's not how decisions actually get made. We just talked about how in many places it's up to the individual provider to make the decision who gets moved out of the ICU and who moves on. And even in hospitals, that could be an administrative decision. And often payer becomes part of that decision-making. Personally, I've seen how my 92-year-old mother had a whole complex of being in the cardiac care unit until her insurance stopped paying. And literally they transported her out at 11:30 p.m. because the payer wasn't going to pay for another day, right? And so as the system functions in very different ways, if we're dependent on independent providers, then we also have to think about how implicit biases enter into how patients are perceived and also how they change prioritizations. People seem to find ways to deprioritize darker skinned people. And that's, you know, that's an automatic kind of implicit bias kind of way. So as you approach this, is your view still sort of the theoretical up in the sky and they'll have to work it out at the level, or is it to consider ways that how your framework can be undermined and try to put in safeguards against that?
Yeah, thank you, Denise. Good question. Can I ask your personal experience, which you kindly shared, was that in the COVID environment or was that?
No, it was outside. And I should add that I am a physician. And so, you know, I'm really familiar with how decision-making goes in terms of patients.
You and I and all of us could have a much broader conversation about general decision-making in healthcare and in quote unquote conventional routine times and concerns around questions of what is medically effective or medically beneficial and who decides, and we should do that. So follow up with me. Now, we just switch gears. So one thing I will say in terms of the pandemic arena and COVID-19 in particular, despite the fact that we don't have a statewide plan in Georgia, just to use an example, you will find that healthcare systems have actually adopted plans which allow for the potential for some consistency in decision-making. Furthermore, a lot of systems, and I can just speak for the Emory Healthcare, we're actually, not only have we not lulled after we created a plan that has some ethical merit, I hope, but we are actually going through triage implementation exercises, meaning we're holding our triage teams and triage committee accountable for looking at material extracted from sample cases, you know, not non-identified, but sample cases, to say, okay, if you are the triage team on call today and you are actually having to make decisions, how would this person actually be identified? How would you think about this person? And we're actually pushing people to think about that. We also have all done implicit bias training, which I think is great, but it's just a part of, you know, the bigger conversation, Denise, that you bring up, because I think the reality is we all need to be aware of biases in many arenas and assumption biases about patients, good, and, if you will, pro and questionable, right? Even if we think this is a patient who's going to do well, why are we thinking this patient will do well? And again, I will say, and this is all in support of your concerns, but I do see people working really hard to continue, you know, treatment very determinedly. So we have many more examples of patients who've spent now months in the ICU, sort of against all odds, because people are advocating for that person. None of the allocation planning that I'm talking about should have any effect in a negative way on that. Right? It's only if we literally got to the place where we had, you know, 4, 10, 15 people waiting on the one ICU bed to come about, you know, that's, so none of that should affect. And so we need to be absolutely committed to continuing to push each of us and each of our colleagues to be thoughtful about in what ways might discrimination or bias begin to rear its ugly head, because we all are biased. We all are. And then in a more, in addition to kind of not exacerbating underlying inequities, I think the question that many of us in bioethics are thinking about is, and what can we do to be about ameliorating some of those? And so are there active ways in which we can say individuals who have who've come to this point in their life with underlying systemic racist and structural and socioeconomic barriers, how do we think in a way about trying to ameliorate that as a starting point in making decisions? And we're really, I mean, people are struggling with that nationally. Even people who really are committed to that. How do we do that is a really powerful question. So I appreciate your you're naming it, and I appreciate your challenge. And I'm on that team of really looking deeply at it with lots of great colleagues, and would love to have you your voice in that as well. Thanks.
Carrie is next.
Yes, thank you. And thank you for a wonderful presentation, very enlightening, particularly for us lay folks. We really have learned a lot here. This is more of a general question. In the turn of the 16th and 17th centuries, Shakespeare's time, there were 2 plagues that wiped out a good swath of London population. Now here in the 21st century, we have a virus that comes into existence and takes over the world in 2 weeks. We're not making a lot of progress here. Should not there be a lot more resources going into the causal factors and their source of these pandemics, of these viruses? And what kind of measure of the resources going into discovery do you see down the line? Thank you.
Thank you. Thank you. Great question. Yeah, I think we have to have some epistemic sort of humility around all of this. You're right. It does, our human foibles and limits seem to be very much on display at this point. I would say on one level, a continued significant investment in our public health effort is vital. And we've seen some concerns about that, I think, in recent years. And in addition, research in virology and related fields, technology is also warranted and important if we're going to be able to take some of these measures forward. And yet, again, a little bit of humility about our limits. We cannot foresee, and those of you who are researchers and physicians on our conversation today, I'd love to hear from you about this as well. It's really difficult to foresee what is coming, right? So again, we knew a little bit about SARS, the coronavirus, sort of related, but this is a novel virus. This is something we had not detected before. I think the reality is that there is a lot known about transmission pathways, and there's a lot not known, right? There's where we have interspecies kinds of issues arising. It's really hard to see where the intersections may occur, but we may have some learned lessons, as we do realize that there seems to have been transmission in wet markets in certain parts of the world, where we saw pre-Camp Funston in 1918. There was an intersection of avian bird migration routes and also transmission by swine flu and hogs in that county. There are some routes that we're realizing that may give us some lessons learned about being careful about the way in which agriculture proceeds or care for animal proceeds. So there are some lessons learned that I think are powerful, but again, there's probably some better experts even online here that may want to speak up about this as well. So I think we must keep this foremost. We need to not go into a lull if we're able to get a vaccine rather, or vaccines that help us with the current virus. That's not going to be the end of this. It's going to continue. The virus will continue and new viruses will appear in the future. So what are we doing to keep this really up front in our national and international minds, and taking steps and putting in resources that allow us to, encounter this differently in the future?
Nick is up next.
Can you hear me?
Hi, Nick.
Hi. So thanks for the great talk as usual and the great discussion. I also want to say that I love the King's Amendment. We should name it like that when it comes in front of the Congress. I had a question about nowadays with the new availability of electronic contact tracing and proximity testing what are your thoughts about the potential loss of anonymity when those are in place? I think they're good techniques, but they have definitely some downside to it. Thanks.
Thank you. And I want to hear your comment about this as well, Nick, so you'll have to come back on. But yeah, I mean, there are very real privacy, confidentiality kinds of concerns that we need to be acutely aware of in this digital electronic age, period. And certainly as we feel more and more sort of emboldened and that it's the right thing to do is to do as much contact tracing as we can so we can notify others and try to decrease the transmission of the disease. But those privacy issues are real, and are there going to be implications for who has that information, and does it influence, other things, insurance, jobs, et cetera. So there are things that we need to be particularly aware of. And at the same time, we hold that in tension with, this is back to our liberty limiting, or how do we think about the good of the public, the common good, the public good, in concert with our ability to say, I don't want you to follow up with any of the contacts I may have had. And so I think, again, it's more than just education. I think we need to build the public's ownership of why this is so important, such that people say, I get it. I care about other people. I'm committed to that. And therefore, I want to be a part of the contact tracing. Now let's all understand what that looks like, what that means, and is there as much effort going into building this out so that privacy issues are taken into account. That, and again, there's a long history in public health of contact tracing in many other arenas. We have a lot to build on. We're not starting from scratch there. But what do you think, Nick?
Well, again, it's a balance between the private liberty and the greater good. And I absolutely agree that people have to be willing to relinquish some of that information in order to, curb down the spread of a disease. I think the problem is what happens with all those people who don't want to do that. And that's the same thing. And I'm seeing in our community here, people who are wearing masks and a bunch of other people who are not. And although there are laws regarding speed limit on the highways, nobody gets a ticket for not wearing a mask.
Yeah. Thanks.
I think some of the problem is that they don't understand this. You gave the stats for the swine flu, 0.02%. Well, if we believe the current figures, it's 100 times that, 2%. And I think that's what, you come out and people, young people say, well, it's no big deal. It's just like the flu. President got over it. So, people need to be panicked. The idea that you don't want to panic the public, to me, it's the opposite. You do want to panic in a soft way. People need to understand that this is a very serious thing, not only for mortality, but for lingering cardiovascular, all kind of cerebral CNS complications. So, I just think people need to be a little bit panicked, and then if we're being invaded by some China, actually invaded by China, we'd all be organized. We'd be like we were when we hated Japan and so forth. We could get organized, but we don't hate this disease adequately to understand its threat to us. So I don't think we're just like, you got people who want individual freedom and they don't. No, it's if they understood the threat, we could classify it as other threats that people could get behind.
Yeah. Yeah, I appreciate your comment. And again, is whether panic is the right word, as you said, but you know, the idea of recognizing a threat, recognizing the reality of this is serious, and that we have to take it so. And even if you happen to be someone who you believe is not going to be deeply impacted by it, there are many other people, even in your own life, in your own circle, who you could transmit the disease to, who would be severely affected. And then, of course, it ought to be just beyond our immediate family and friend circle. We ought to be caring about our community at large and wanting to solve the problem, right? You know, we would like to get this under control. So waiting on herd immunity, percentages of people to be infected in order for it to be less likely to be spread, or just waiting on the vaccine is not an adequate ethical response, in my opinion, by individuals or by communities. So I agree with you, Spencer.
And Angelica has her hand.
Thank you very much. What an interesting presentation. I'd like to ask a question related to the vaccine distribution. I'm impressed by the complexity of the ethical considerations, all those dimensions, how one criterion affects another criterion. But ultimately, is it going to be individual physicians or pharmacists who administer the vaccine? Will they have been given this complicated way of thinking about to whom to give it? I mean, I guess I'm asking, ultimately, that individual who administers the vaccine, it's that person's decision who should or shouldn't get it. You know what I mean? All the fancy systems and policies and institutions that give all this deep thought, but doesn't it come down to, you know, the nitty gritty of what individual decides to give the vaccine to what individual?
Yes, that's a good question. So in reality, once tiers or phases for immunization have been decided, whatever they are, you know, so let's just draw one out of a hat, you know, that individuals over age 65 are going to be prioritized. Then that means that is the population who will then be eligible to go to those delivery points, whether pharmacists or, you know, more tents set up around our communities. And one of the challenges there is making sure the access to those vaccines among that population is possible, right? Readily possible across an entire community. So people aren't being left out because they can't get to that. But so that should, and usually does, I'll say in the past, shift how much decision-making is at the point of the provider, right? So that in other words, the phasing will limit who actually has the ability to go in and get their providers. And during, I guess, 2009, 2010, here I am, an ethicist, right? Just, you know, over on the side, I'm getting calls from some of the people, like important people around Atlanta, asking how they can get in to get this vaccine. Wow. And I'm telling them, you know, it doesn't work that way, right? I mean, you know, so if your local physician, if that's a place where you're going to go, where they have the adequate cold storage to administer X vaccine, they're going to only vaccinate people within the tier or the phase who has currently been approved. Does that mean there couldn't be some people making different choices? Possibly, yes. But that's very minimized, I think, by the distribution channels that are set up and the adoption of these tiers. I think another area that is an interesting wrinkle is, of course, you'll have these recommendations from CDC and the ACIP, and then there's going to be some implementation at like the state level. So we may find some variation at the state level. Some of that may be, you know, somewhat justified. For example, if we said essential workers are going to be a category that at whatever tier we should focus on. Well, an essential worker in some communities might be, I work at the local meat packing plant, which has been heavily devastated by this. And so an essential worker in our community may be a different person than in another community where there are, 10 long-term care facilities that were, heavily hit. So, it's, there may be some variation that I think is, ethically reasonable in my opinion. But again, there should be some uniformity of the tiering and the access availability over those first months or however long it takes for us to get adequate vaccination.
And the pharmaceutical companies will respect to whom their shipments should go. And, I'm just.
Yeah, generally speaking, again, I can't speak for what exactly will happen this time, but there are agreed upon distribution pathways for manufacturers, pharmaceutical manufacturers to distribute. Sometimes they're at a state level, like it all comes into a centralized place and then is distributed. It very much depends. I mean, so there is more of a potential for agreed upon channels for distribution, again, with the goal of equitable access.
Great. Thank you so much.
Sure.
And Denise has her hand up, and this is the last hand.
Okay.
Why do you think, as you showed the history of previous pandemics, why is this the first one that brought the world to a stop? Right. Oh, the plague ultimately had an impact on how labor and employers related to each other, just because there was such a labor shortage, and it gave a lot of advantage to laborers. But there's been no other disease that literally brought the world to a standstill. Is it because we are so much more globally integrated? Is it because standards of living have risen so that there's so much disposable income that drives economies and therefore the way countries work? Or is it just a different sort of political and mental approach to disease?
Great questions. I wish I would knew the specific answer to all, but I can say a few things. I mean, over the centuries, of course, 1918 is another one that arguably worldwide was very devastating. And of course, again, that was.
They carried on a war.
Yep, they did.
Right?
They
I mean,
did.
it didn't impact how much of the world went.
Yeah, and yet there were huge impact on the ability to actually carry out the war. But anyway, we can talk further about that. We will talk further about that. But yes, but there are some things that are quite different. Again, there's been advances in disease recognition, virology that have led us to the point where, again, what do we see? This explosion of pharmaceutical manufacturers trying to come up with the vaccine. That's really a fascinating whole arena in of itself. The rapidity of transmission of the disease due to our ability for people to travel much more broadly and quickly. So again, if we actually could ever get a map of exactly what happened, if we assume it all did start in Wuhan, China, how many days did it take for 50 countries to have been affected was probably pretty small. And then the explosion. I mean, we're beginning to recognize, I think even in this country, that where we thought we saw the first cases are probably not where the first cases were, that there was already activity in different areas. And so the explosion of travel, the international quality of our communication and our industry, sharing of resources, in terms of our dependence upon in other countries, interdependence on each other for being able to carry certain industries forward. So many things, I think, have shifted dramatically over this century that have led to this enormous impact on how communities have actually responded, but also it is the presence everywhere in the world almost at once, right? It happened so quickly. So nobody was able to come to the aid of another part of the country or the world because everyone was tackling this at the same time. So I think, and again, as we've talked about, some countries were much quicker to say, shut down, right? we're stopping, right? And many, so there's a whole political overlay and decision in terms of historical patterns about how quickly people reacted and how they reacted. So I think this, and again, it's been a bit of a hyper virus in the sense of how do we think about the impact on individual lives, both in terms of impact on illness, severe illness, ICU, and hospitalization. So the overriding of our healthcare systems because of the severity of the disease, and then death rates, just sort of enormous case fatality ratio compared to many other prior. So I think it's a constellation of things that have made this so difficult. And we talk about, you know, lives or livelihood, right? People who wanted to make sure they could care for their family, and industries who didn't want to give up on production. You know, so many factors rather makes this one a complex problem, but also a particularly difficult one that we have not done a very good job in solving. Right? Thanks so much. This has been so rich for me to communicate with all of you. Thank you so much. It's been fun.
Thank you so much, Kathy. And it really is time to go, but I can't raise my blue hand, but I do have one question that seems to be an ethical question that hasn't come up. And, you know, when we talk about critical resources, once you have built all the ICU rooms you can in a certain time, you can't build more. You have to wait for that. Once you've gotten the limit of PPE, you have a certain amount, and if you can't get any more for a while, you can't get any more. However, it seems like that in terms of healthcare workers, that's not been quite the same. So if a standard for a healthcare worker is 40 hours a week, well, if they work 50 hours a week, you have more healthcare workers, or if they work 60 hours a week, or if they work without the necessary PPE, they can still be managing patients. And yet it seems like we have seen terrible sacrifices. Early on, there were a lot of healthcare workers dying, in part because they didn't understand all the risk. But we've seen a lot of healthcare workers who have suffered, certainly psychologically, and just exhaustion and so forth. And so I realize these people, you know, that's their life work and they've chosen to be dedicated. But on the other hand, what are the ethics of a healthcare system letting workers do that, or even encouraging them to do that?
That's a great question. And actually, there's been a fairly robust ethics conversation about, you know, what are the quote unquote resources needed to provide the level of care that's needed during COVID-19, including, as you said, PPE and ventilators and ECMO units and all these different things. But the shortage of healthcare providers has been a really important topic for a lot of organizations, but just nationally as well. And so I can just share that a number of healthcare systems in the Southeast that we're working with have very much asked that explicit question, right? So it's one thing to say, would you work an extra 10 hours a week? It's also a different thing to ask, well, let's see, you usually have 2 or 3 ICU patients. Can you now do 4? Can you do 5? What can you possibly do in terms of providing adequate care for a patient? And would there simply be limits that would lead a healthcare system to say, we can't take any more patients, right? And I think there are systems that sort of know what that would mean. And of course, we've watched, in an interesting vein, a number of healthcare providers come from areas of the country when there was a surge. For example, in New York, a lot of nurses and physicians, others traveled to New York, had the legislative ability to practice in a state that they didn't typically have a license in, and were there for months. That also is problematic sometimes, though. That means we're pulling people away from areas that had yet to see the surge, where they needed to be also on hand. And as you say, Gray, we're putting those people at increased risk. They're choosing it, but should there be some limits there? So just to say, not that there's been a clear, resolution of everything, but that there are a lot of systems that have thought very carefully and are also procedural ethics or procedural justice wise, actually talking with their own healthcare providers about that. Like, what is it? How do we think about this? What are the limits? When should we not be asking for more? Can you tell us that you're at your limit? Do you feel that you can tell us? So I'm glad you brought that up. I think in some ways, healthcare providers themselves may be one of the most important limiting aspects of what we can and should do. So we hope we're building up our ventilator stockpile and we're getting more PPE and that sort of thing. But the people are really probably our most crucial resource in many ways.
So once again, thank you so much, Kathy. You can see that there's been a huge amount of interest among our group in talking about this, and I just greatly appreciate your coming.